A major push to combat HIV in South Africa is underway. The Department of Health, in partnership with the South African National AIDS Council, has just launched a critical new treatment campaign. The goal is to bring an additional 1.1 million people living with HIV onto treatment by the end of 2025. This initiative aims to close a significant treatment gap and accelerate progress towards ending the epidemic. Let's now discuss the details of this campaign and the strategies that they'll be using and the challenges that they're anticipating in reaching this crucial target. We are joined by the South African National AIDS Council CEO, Thembisile Xulu. Thembisile, a very good morning to you. Thank you so much for making time for us. Tell us how you came around the figure of 1.1 million. And when the minister was speaking on this, he said that the majority of that 1.1 million are men.
Morning, Eldrin, and good morning to your viewers. The figure of 1.1 million comes from the targets that have been set by the United Nations, which are the so-called 95-95-95 targets. So we know that for the second 95, which is the number of people on treatment, we are only at 79%. And in order to bridge that care gap from 79% to 95%, we need an additional 1.1 million. Now, the data does tell us, Eldrin, in terms of who is on treatment, who has dropped off, and who is not on treatment. So we know the target populations that we are looking for, and men are particularly high on the list of people that we are looking for. We are also looking for key and vulnerable populations because the number of new infections is quite high in them, and they face a lot of stigma in terms of accessing care and treatment services. We are also looking for children, but most importantly, we are also looking for adolescent and young people. And this is us looking at the data that comes when we measure how many people are on treatment, how many people know their status, how many people are staying on treatment, and how many are virally suppressed. And the data is showing us that on the treatment, we have a gap of 1.1 million.
Okay, I'm just quickly going to bring up the poll that we are running this morning. So we're asking our audience in relation to this conversation that we are having and also the remarks that were made by the minister. Why are South African men reluctant to take HIV treatment? And for our audience, you can scan the QR code and choose any of the three options there. But Thembisile, out of the three options that we have there, stigma and pride, access to treatment, and lack of awareness, what is actually leading is stigma and pride at 82%. And you just touched a bit on that. But why is that the case that we speak of stigma when it comes to men, but not necessarily when it comes to women?
Stigma is an important issue when it comes to men because men, by nature, don't like spending time in clinics. And I mean, some of the rhetorics that were told yesterday is that they also don't like spending time in church. They are obviously home, they are breadwinners, they are busy, and spending long queues in clinics with women that are there with crying children is not necessarily part of what men want to find their time doing. So what we are looking for in terms of providing is men-friendly mobile services that will go to the men and find the men where they are. And as much as it might sound distasteful, if men are sitting in taverns, that is where we want to find them. If men are sitting in places where men gather, that is where we need to start looking for them, because even the attitudes of healthcare workers don't just deter women and other populations, but they also deter men. And that is why we are saying men-friendly services as defined by men. So we are talking to the men and we are asking them, where can we find you? Where are you? Where would you like services to be delivered? And men, for instance, instead of receiving a 1-month pack of antiretroviral treatment, when you are a person living with HIV, they would rather receive 6 months so they don't have to come into constant contact with the facility. And those are some of the strategies that we're employing to make sure that men are coming through.
Yeah, and that is, I think it is the treatment action campaign, if I'm not mistaken, that has also pushed for at least a 6-month batch of antiretrovirals that are given to patients. But then with that said as well, how do you ensure that you're able to monitor the viral load as well as looking into whether the ARVs that are being given to this particular patient are doing the right work?
All right. So thanks again, Eldrin. So one of the things that we do when we put our patients onto treatment is there is a counseling component where they are advised on how to take treatment, how often and how well to take treatment to make sure that it works. And then when we see them on a 2-yearly basis, we take a test that is called a viral load. And the viral load tells us how well the treatment is working. And by then, we look at whether the virus is continuing to be suppressed within your system, because we want everybody to reach what we call an undetectable viral load, because once your viral load is undetectable, then you are not able to transmit the HIV onto any sexual partner. When we find that the viral load is not decreasing, Eldrin, we have tests that we do for resistance, and we are able to check which of the antiretroviral treatment regimens are you no longer responding to because you are resistant, and therefore should we be considering you for second line or for third line treatment. So we do have options for people that have become resistant, but the current first line treatment that we have is called dolutegravir. It's got a very high threshold for resistant, and it's actually quite a forgiving drug. And many people are doing quite well in terms of quick viral load suppression, CD4 counts coming up, but we are able to detect whether the treatment is working when people are on treatment, because we do only do the viral load twice a year, every 6 months.
Okay, and children also being part of the target population, how are you going to get to them?
So children being part of the population, it's actually a multi-sectoral approach. In 2022, the then Minister of Health signed a pledge for South Africa to be part of the Global Alliance to End AIDS in Children. And one of the things that we are doing is we are saying our children are out there, their mothers are on treatment because the men are doing much better than the women. Let us try to catch them at every area that we can. And let me give 2 examples, Eldrin. We complain in the health sector that children are not on treatment. Yet when you go to the Department of Social Development, you find that social security grants are being collected for children. So it's a multi-sectoral approach where we are working with social development to make sure that we get the data and we are able to get to those children when they are actually collecting their grants in order to bring them back onto treatment. At the same time, our children are coming through for the extended program on immunization, and we are supposed to be testing them and also giving them immunization. But we are finding that at the final stage of testing, which is 18 months, we are not testing enough children through the immunization program. And that is one of the areas where we are going to find our children and bring them back onto treatment. We also have much tastier, much palatable regimens available for our children. And we are finding that that is making it easier to make our children take treatment and to stay on treatment.
Yeah, and all of this, Thembisile, obviously requires money. We know with the geopolitical tension between South Africa as well as the United States and the fallout with the UN-AIDS as well. How do we plug that 17%, that hole that had been plugged by UN-AIDS, considering this decision that has been taken?
Okay, thanks, Eldrin. I'll speak for UN-AIDS. UN-AIDS is still very much in the picture as the coordinating body. So it's USAID that
Sorry, USAID, apologies for that, yeah.
It's USAID that has issued the executive orders, but some of the agencies that are supported by USAID, the likes of CDC, have actually been allowed to continue with some of their work, and yet some of the work has been told to stop. USAID in particular has got shorter time periods, like they have been asked to submit work plans for 30 days. I gave an example and I said that multi-month dispensing is one of the things that we are encouraging our clinics to do to make sure that our patients don't run out of treatment, because our minister did say on record, South Africans, despite the executive orders, will not run out of treatment. So clinics are no longer issuing 1 month. At best, they are issuing 3 months, and where possible, they're issuing 6 months. The fiscal gap that we are trying to fill for the HIV program is about 17% and support. So we are trying to make sure that we are speaking to other philanthropists, we are speaking to other partners to see how they can assist. but the impact has mainly been on the human resources. And where the human resources are within government facilities, we are integrating services, not just for HIV treatment, but for prevention and for TB, and making sure that with the little that we have in terms of money, we are trying to achieve more. Like we've been able to launch this campaign despite the shifting geopolitics, because we are committed to making sure that South Africa is able to eliminate HIV as a public health threat by 2030.
All right. Thank you so much for your time, Dr. Thembisile Xulu, who is the CEO of SANAC there on that 1.1 million campaign that they've launched, Close the Gap, where they're targeting majority of men